Our capstone project was on the ethics of AI in medicine, and the essential question we were trying to answer was, should AI ever be permitted to make medical recommendations that override a physician's judgment? And I'm Rose.
And I'm Jackson.
And I'm Jacob.
And we also worked with Addison, Irving, Jacob S., and Logan on this project.
The ethics of AI in medicine. How is AI being used in medicine? AI diagnoses diseases. It can take information given from x-rays, CT scans, and give a diagnosis. Personalized treatment. AI can take a patient's diagnosis, medical history, yada yada, and recommend treatments that best suit that individual. It can predict health risks. AI can identify patients that are at high risk of developing diseases, making it possible for doctors to take care of the disease at an early stage. And it can identify patients in need of care. AI analyzes patient information to determine which patients should be treated with the most priority. Now, you might be asking, how does this pose ethical challenges? Well, first, there's patient autonomy. Patients have the right to make informed decisions about their healthcare. There's bias and fairness because AI systems learn from existing medical data. So if the training data does not represent all populations equally, AI may produce less accurate results for racial, ethnic, gender, or age reasons, leading to unequal outcomes. Liability, because an AI system, if it makes an incorrect diagnosis or treatments, it's pretty hard to determine who's legally responsible for that. Privacy and data security. AI requires large amounts of patient data and to function effectively. And maintaining the privacy and security of patients' data should be a top priority, and it is a challenge to implement AI while also focusing on that. And the last issue is transparency, because when an AI delivers a diagnosis, sometimes experts are not able to determine how the AI got there. And a lot of the time, AI will not tell us, and if they do tell us, there's a chance that the AI is lying to our faces. And if we can't tell that, that's a huge issue. What does this mean for the future? While AI may have plenty of benefits in healthcare, it should be used as a tool to support doctors, not to be doctors. As AI becomes more common, hospitals will need to make sure it is used fairly, safely, and in the best interest of patients.
So we've come to the conclusion that AI at this point should not be allowed to override a physician's judgment. So here are some real world examples concerned with the ethics of AI in medicine. So concerns with patient autonomy were brought up with the IBM Watson Oncology Predictive Software. This was a supercomputer developed to compute medical records in order to instantaneously generate personalized cancer treatments for patients based on their prior history and other health measures. However, the system was drilled with an inadequate number of real patients, resulting in the generation of faulty recommendations. If a patient were to be recommended a treatment from this software, it would create a conflict with their personal autonomy due to a lack of informed consent from the limited options presented. An evaluation of healthcare risk algorithms in Obermeyer et al. Provided insight into issues regarding the biases and fairness of AI in medicine. The algorithm analyzed in the meta-analysis was used in American hospitals to identify the need for extra medical care for patients, but the algorithm instead operated by predicting relative healthcare costs. As the historical medical spending for populations of color was lower than for that of white patients, the algorithm concluded that people of color were healthier than equally sick white patients. This meant that the patients of color had to be sicker in order to be recommended and receive the same medical treatment. Because of AI's involvement in this instance, healthcare disparities and biases were further perpetuated. The issue of liability with the further integration of AI in medicine is brought up with the IDXDR software by Digital Diagnostics. This highly accurate software independently determines if a physician should see an ophthalmologist by analyzing retinal photographs, and it operates with no physician in the loop. However, as the first FDA autonomous AI in medicine, it brings up the issue of who should be held liable for a misdiagnosis, the physician or the AI, and how would that be handled legally. An instance where privacy and data security were compromised because of AI's involvement in medicine was with Google's predictive health software in UChicago. In order to train the machine learning algorithm, hundreds of thousands of electronic patient records were shared with Google. These records, however, contained personal health information, including timestamps and physician notes, which could be used to identify the specific patients. So a class action lawsuit was pursued against Google for sacrificing patient privacy. Lastly, the EPIC system sepsis model clearly depicted the issue of transparency with AI in medicine. This was a model developed with the purpose of predicting sepsis, but numerous evaluations found that there were both missing cases and false positives. With this case, a significant challenge of including AI in medicine is presented, the black box problem. Essentially, this means that when an AI model arrives at a faulty conclusion, but because there's no way to determine how and why, the functionality of the system is undermined. Tying this back to the EPIC sepsis model, clinicians were unable to determine how the system arrived at its conclusions, so its lack of transparency was clearly displayed.
Now, in the scenario we provide to you, there are three major stakeholders who all have competing values: the patient, the doctor, and the AI. The patient's values can be summarized as obviously living in general and cost maintenance, but to further elaborate, the patients the patient will care more about how they end up after treatment, and they may value the judgment of another human, such as the doctor, over an AI. They also may trust the doctor or AI more than the other one, and they also may have biases against certain doctors/AIs, but specifically doctors for race, ethnicity, gender, and other factors. The doctor, on the other hand, will be more of the commonsensical and practical values in the scenario. Their goal is to save as many lives as possible and they're the ones with the expertise and education, not the AI, and they have the legal responsibility. So if they mess up, they're the ones getting in trouble. If the AI messes up, they might get in trouble. But if the AI messes up, the AI is not going to get any repercussions. And as with the patient, the doctor may have biases against patients because of their skin color, gender, age, plenty of reasons. And the doctor cares a lot about the reputation and the patient. The AI can be summarized as caring about statistics and probabilities. They want to deliver as many data points as possible for the company. They want to make the least amount of perceptible errors as possible. They don't necessarily have a legal responsibility. And using data, they can create biases against patients or doctors.
With the increasing integration of artificial intelligence in medicine, numerous benefits and risks are being presented. Beginning with the benefits, AI systems have shown that in certain instances, their diagnostic and medical accuracy is greater than that of a physician's. And through data-driven decisions, medical mistakes can be reduced, which can help reduce costs. In that same vein, medical expenditures for patients and hospitals will be reduced because the amount of people paying for treatments that they may not necessarily need will decrease. And because diseases will be caught earlier, patients won't need costly treatments as much. Also, AI has been able to monitor the spread of diseases, which assists with implementing the necessary public health measures to stop their spread. And furthermore, the pairing of AI with skilled physicians is resulting in unprecedented surgical progressions, the development of medications, and it has the potential to improve patient-doctor relations. The last and most significant benefit is that both time and resources can be saved when AI is able to do menial administrative tasks, therefore giving doctors more time to focus on their patients. But despite these incredible benefits, the drawbacks of including AI in medicine must not be overlooked. As we saw with many of the real-world examples, AI isn't always superior and can make generalizations that harm its ability to help patients, which was seen in Obermeyer's study. Also, challenges with understanding AI can make it difficult to implement in a hospital setting. AI poses threats to patient confidentiality through the sharing of data and a lack of transparency. Also, clear guidelines regarding systemic accountability and patient privacy aren't really in place. General skepticism of AI systems due to failures, such as with what was seen with EPIC sepsis in Google Predictive Health, and out of fear that AI will put medical professionals out of work, are inhibiting the implementation of AI. And lastly, because AI's specific answers in a predictive model aren't exactly replicable, issues can't be traced, and in a healthcare setting, mistakes can mean life or death.
Now that we've argued when AI shouldn't override a physician's judgment, it's fair to ask if there are exceptions. There are cases where AI should be given more independence and where it actually makes sense. Let's look at some examples. In the case of IDX/-DR, IDX-DR screens for diabetic retinopathy without any physician overview at all before referral. And it's FDA cleared because its accuracy matches or beats the specialists and the doctors. The argument here is that in narrow, high-volume tasks with low ambiguity, requiring physician sign-off can add or delay error and reintroduce human error without improving the safety of the patient. This suggests full AI autonomy might be justifiable, but only if tasks like screening or triage flagging, not for complex diagnosis or treatment decisions, is applicable. It's important to be precise when talking about IDX-DR and what it actually does. It doesn't override a doctor's judgment. It operates at a stage where no doctor is making a decision in the first place. Complex diagnoses require context AI can't access, like patient history, personal reference, etc. The Obenmeyer and Epic sepsis cases proved that even high accuracy AI can produce biased or falsely confident results. So autonomy over one narrow step like screening is not the same as giving AI authority over the physician's final call. Based on everything we've covered, we'd recommend 4 guiding principles. First, protect the human autonomy by keeping AI in a supporting role and letting patients know when AI is involved in their care. Second, promote well-being by testing and monitoring AI before and during use. Third, establish accountability, meaning a person or institution is always responsible for the AI's actions. And fourth, promote responsible AI by limiting it to well-defined tasks that's actually proven to handle. So to answer our question directly, no, AI shouldn't be permitted to make a medical decision that overrides a physician's judgment. Watson, the Obermeyer algorithm, and the Epic sepsis model all show that even well-tested AI can fail. There's no clear accountability when it does, and complex diagnoses require context and values AI simply isn't built to understand. AI should expand on what physicians know, not replace how they decide. Narrow, low ambiguity tasks like the IDX-DR are the exception, not the rule.
Thanks so much for listening to our presentation.
We really appreciate being chosen.
And we really hope you enjoyed our presentation.
Thanks so much. Bye-bye.